Today, I want to do something a little bit different. I know I usually do tests on this channel and I try to help out students, but this one's going to be a little bit different. I want to talk about CHF, okay, congestive heart failure. Really, what I want to get down into are the 5 different presentations that this patient can have, at least 5 that I've seen. If you've seen something different or you want to chime in, please comment. We can have that discussion. I'd love to hear what you guys have experienced. Maybe some of these 5 different presentations I talk about, you've seen before. So today, it's not just for the students, also for the people that are out in the field. Maybe you work in an ER, maybe you work in the back of a rig. I think it's really important to understand what CHF is, how we treat it, why we treat it the way we're treating it, why we choose these medications, and then how this patient is going to present. Maybe a little bit different than some of your other shortness of breath patients or other cardiac patients, obviously. So let's jump into this and stay to the end because, again, there's 5 of them. And the last one you might not expect. Okay, so first off, we got to talk about what is CHF or congestive heart failure. It has to deal with left-sided ventricular failure, right? We call it LVF. Now, your left side of the heart, we all know, is your strong side of the heart, and that strong side of the heart is what pushes all that blood and perfuses the entire body, right? So that left atrium is actually where we get oxygenated blood from the lungs that drops down through the mitral valve. Once it gets into that left ventricle, the left ventricle has really thick muscle walls and is able to push that blood throughout systemic circulation. Now, the problem when you have left sided heart failure is the right side of the heart, at least in the beginning of LVF, the right side of the heart still supplying the same amount of blood, okay, as normal. The right side, remember, collects deoxygenated blood and it's just basically feeding it into the heart and making it go through that cardiovascular blood flow route, right? So it goes from, I'm not even going to go through the blood flow, but we all know that once it drops into that right ventricle, it goes through the pulmonary arteries and then into the lungs, right? To get oxygenated. Now, the problem is that left side starts to get weak and it's still getting the same supply that it always gets. Some of that blood starts to back up. Okay. Some of that blood supply isn't making it through the heart like it used to. Right. And the left side of the heart's just not doing its job. And when that blood starts to back up from the left side, it goes back into the lungs. And when it goes back into the lungs, that's when we hear rales. Okay. Rales, also known as crackles. We get to hear fluid in the lungs. Okay. Now, I want to talk about the classic CHF patient. Everyone who's been around for a little bit has seen this patient. The patient has their tachypnic, they have fast breathing, right? Put them on end-tidal. We have very short plateaus on the end-tidal waveform. My patient obviously has bilateral rales, crackles, and I have a very high blood pressure. One thing that I do have to tell you, when you see this patient, remember this is cardiac in nature. Ultimately, I mean, the patient looks like a respiratory patient, but this is a cardiac patient. We need to get a 12 lead EKG. This patient requires 100% ALS treatment. Now, again, high blood pressures. I'm always looking for that, right? They're breathing fast. They're blowing off a lot of CO2. So I might see some lower CO2 numbers. Very common. Now, once we get this patient loaded up or we start treating this patient, the first thing that I want to try to get treatment wise is CPAP. Okay. Maybe in your hospital facility or maybe on your, uh, in your protocols, you guys are doing BiPAP or bi-level. But CPAP or continuous positive airway pressure is the go-to, right, for emergency treatment, at least in the pre-hospital setting for these CHF patients. Now, a couple things I got to note on CPAP is first, I have to have a good blood pressure, right? My patient has to be perfusing. So I like to see these high blood pressures. The second I see that high blood pressure, I'm like, okay, I can give this patient a CPAP. But there's a caveat to that. That patient has to be coachable. So they have to be talking to me. They can't be just staring off into the distance while I'm trying to coach them to breathe. They have to be able to watch me. I usually tell them breathe like me, and I really emphasize my exhalation because what's happening is we're creating a positive and expiratory pressure, known as PEEP. Right? Our therapeutic range is between 5 and 10. Okay, and that's centimeters of water. That's how they measure it. But remember, whenever we're applying that CPAP, I want to achieve at least 5, and I'm going to work my way up as needed. Now, one thing I want to tell you about CPAP, and I know this is not supposed to be a CPAP discussion, but PEEP is going to depend on my patient's expiratory um, force. Okay, if I put a CPAP on somebody and I flow it at 10 liters per minute, I'm not going to get the same PEEP from every single patient that I have, right? If I have somebody who's really forcefully exhaling rather, they will be able to get or achieve a lot higher PEEPs versus somebody who is very tachypnic and maybe their breathing is a little bit more shallow. That PEEP is, I'm going to require a lot more liters per minute to achieve the same PEEPs. Okay, so that's one thing I need to know about that patient. Next treatment that has to happen is nitroglycerin. Now, a lot of people are kind of unsure as to why. Why on earth are we treating this patient with nitro? It's not like they're having chest pain, right? The reason behind it, remember I was talking about what CHF is, and CHF is getting a excess amount of blood that's coming from the right side of the heart, pushing it through the lungs, and that left side again isn't able to compensate for it. So, how can we help out that left side of the heart? Well, we could reduce preload. Okay. We could reduce the amount of blood that is flowing through the heart at any given time. And how do we do that? With nitroglycerin. Okay. What I recommend is sprays. I recommend sprays. Don't, if your system uses tablets, just be mindful. Having to lift off the patient's mask and trying to throw tablets into their mouth can be really challenging. And I don't want anybody to choke, especially if they're breathing fast. So sprays are preferred if you have it. Okay. Dose is still the same. Obviously, follow your protocols, but for national standards, it's still 3 doses. Right. Each one is zero point 0.4 up to 1.2 milligrams. So we're treating this patient with just CPAP and nitro. Every single time that we give a spray of nitro, we're reassessing that blood pressure and making sure that the patient isn't tanking too much on that systolic. And we want to try to maintain perfusion, obviously. But just with the CPAP alone, remember that continuous positive pressure, it not only opens up the alveoli, right? Not just opens up alveoli, but it also helps with pushing that fluid out of the lungs. Your lungs are like a sponge, okay? And if I put pressure into a sponge that has a lot of water in it, water will seep out of the sponge. So it's the same concept with your lungs. We're trying to force that water out of the lungs. At the same time, we are trying to open up the alveoli to allow for gas exchange. Some of you might be saying, Mike, why haven't you mentioned Lasix, right? Loop diuretic. The reason why I haven't really been talking a lot about loop diuretics is because not many people are using them anymore pre-hospital. Is it a good medication used for CHF? Absolutely, right? Now, the reason why loop diuretics kind of got removed from the hospital setting is the discussion on, do we know for a fact that this is CHF? And is it possible that responders are giving this loop diuretic to patients that have an infection? The answer is yes. And one of the first contraindications for Lasix is an infection. Second, hypotension. Third, dehydration, right? Some of these patients that we're running that have CHF, or that, I'm sorry, that have rails, if they have pneumonia and we give them Lasix, huge contraindication. Okay. And this is the reason why most agencies have gotten rid of Lasix or just because people are giving it to the wrong patients. Also, the national registry and national standards for paramedics, they dropped it. Okay. So they got rid of it. Not saying it doesn't work. And if you're 100% sure that, yeah, man, this patient is a CHF patient and they have the high blood pressure, classic presentation, or maybe the anxiety presentation, yeah, Lasix is a great medication. Remember, that just gets rid of fluid, right? Excess fluid, which could potentially help that patient out a ton in the long run. Okay. So that's the first presentation, high blood pressure, classic CHF. The second patient, okay, a little bit different. It's the same vital signs, the same just about everything, still tachypnic, but the patient is not going to let the CPAP go. Okay. And what I mean by that, you're going to place the CPAP on the patient, and the patient's going to have a complete meltdown. Okay. They're going to take it off, they're going to rip it off, they'll literally fight you. Okay. If you want to put the CPAP on, they're that claustrophobic. They're so worried. They're so anxious with everything going on. Um, we have to have empathy for these patients, but at the same time, we need to treat them because this patient getting worked up like that with already fluid in their lungs, this patient can decompensate and we can be working a code if we're not able to treat them. So I call this one CHF with anxiety. How do we treat this? We can actually use benzos, low dose benzos. Please do not snow these patients. Okay. Maybe depending on the size of the patient, 1 to 2 milligrams of Versed, maybe even less depending on that patient. Use whatever benzos you guys are using, but just be mindful. It's okay to help this patient relax, right? This is a scary situation that they're in. And we want to lower that pressure. We want to lower that preload for their heart, right? We also want to put this CPAP on them. And the only way we might be able to achieve that is by benzodiazepines. Okay. That was our second presentation. So now our third presentation looks a little bit different, actually, a lot different. This patient, they appear ashen. They might look pale. They're diaphoretic. They look like they're in shock, okay? But they're still tachypnic. They're still very worried. This patient might have been short of breath for a lot longer of a period. Get them onto the monitor. They're still able to follow your commands. They just look really tired, and be mindful of that. As soon as you see this patient and you hear the bilateral rails, um, pay attention to their skin tone, right? So we get them onto the stretcher and we put on a blood pressure cuff, and you get hypotension. Immediately, we got to know that this patient is in cardiogenic shock. Okay. I got a patient with rails. This patient has obvious cardiac history. Okay. And I see pedal edema, right? I'm leaning towards a CHF. I'm not saying that this is like, oh, the second I have rails and a low blood pressure, this has to be cardiogenic shock. Obviously, it could be pneumonia with sepsis, right? But we need to be able to narrow this down that this is a cardiac patient. And once we do that, we need to start leaning into the cardiogenic shock realm. Okay. Cardiogenic shock's an interesting one because we have hypotension. The first thing that we want to do whenever we see hypotension, especially in emergency care, is we want to try to increase pressure and we want to give volume. I know right now is an interesting time to discuss volume and crystalloids and things of that sort, but this patient um, doesn't necessarily need volume. Their issue is not a volume problem; it's a pump problem, right? The heart's not working. That's what cardiogenic shock is. So the pump just isn't working like it's supposed to. So if my patient's hypotensive, can I throw that same CPAP on them? The answer is going to be no. Okay. Remember, I said if they're hypotensive, don't use it. The reason why we can't use CPAP for hypotensive patients is continuous positive pressure is going to build up an intrathoracic pressure, and an intrathoracic pressure is going to decrease cardiac output. Now, if I decrease cardiac output and I already have a low blood pressure, my blood pressure is just going to get lower. So we want to refrain from doing so. Instead, we're going to be using a non-rebreather mask. Okay, non-rebreather, we can flow it at 15 liters per minute. And then we need to start trying to fix the pump. How do we do that? We'll do that with an inotrope. Okay, we have to bring up pressure. A really good one to consider is dopamine. Okay, dopamine is an inotropic, chronotropic, and bromotropic. Okay, if you remember what that is, inotropic means contractility, the strength of those contractions, right? Chronotropic means the rate, how fast can it beat, and then dromotropic is the conduction velocity, so the actual velocity of the conduction cycle, right? And those three combined by using dopamine will increase rate and ultimately increase pressure. Now, if you use push press epi, maybe an epi infusion, maybe you're using levo, whatever you use as a pressor, this is the time that we need to consider it. Okay. All we're trying to do again is to sustain perfusion. That systolic of 90 is what I'm looking for, right? As a provider, especially for EMS, I'm trying to sustain that pressure at least above 90. And I'm going to be fluctuating my pressor, we call it titrating to effect, to obtain that perfusion. At no point do I say, okay, well, now I got my blood pressure where I want it. Now I'm going to start giving sprays. I just want to transport this patient, right? Using my pressors, I'm giving the patient oxygen. And once they get to the hospital, then they're going to switch over to BiPAP and they have a lot better hands on that patient. Maybe some of you might be doing really long transports, so maybe you're doing nitro drips and things of that sort. So again, follow your protocols. This discussion or what I'm talking about is mainly for you guys and girls who have shorter transports, okay, where you guys are sending off this patient. Just be mindful. Don't be loading them up with vasodilators. Number four, okay, number four is going to be the patient that many providers are gun shy on. And this one we call the respiratory failure patient. You might be, and tell me if any of you have ever been on this call. You're responding to a shortness of breath. You're walking down a hallway, maybe of a nursing home, and you can hear the rails down the hallway. Very heavy rails. And as soon as you walk in and take a look inside the room, the patient's laying supine. First problem, right? Patients that have fluid in their lungs suffer from orthopnea, right? Positional dyspnea. This patient needs to be sat up in high Fowler's position. So that fluid by gravity would settle down, right? And it allows the patient to breathe. That's why you don't want to lay these patients back. You always want to sit them up. Um, it's crazy when you walk in on that patient and they're actually laying back and they're not fighting it. Okay. This patient probably has been short of breath for a while now. I'm going to tell you, the second you see this patient laying flat and you hear the rails, first thing I always want to do is I always open their mouth and see if maybe it's upper airway, maybe they just have something in the back of their throat, maybe they're aspirating, maybe they were eating while they were laying down. It's a nursing home. If I don't see anything, or if I see froth around the mouth, we're going to play right there, right? We're going to be intubating. We're going to be taking over the airway. These patients require aggressive airway management. Now, this failure patient, they are not going to be 100% with it. Okay. They might talk to you. They might say something like, help, help, help me. I can't breathe. They'll say these things, but they're not going to follow commands. Don't make them walk. Don't even try. Um, if you put them on your stretcher and you sit them up high Fowlers, they'll even start the head bob where they're trying to keep their own head up, but they can't even manage that. These are all very bad signs. You're going to notice that their saturation, O2 saturation is going to be terrible. Their end-tidal capnography might even be high because now they're retaining CO2. Their breathing is just very shallow. These patients, we need to take over their airway. Okay. The use of something like etomidate, benzodiazepines. Maybe you might work in a service at RSIs and use paralytics. Whatever you're using, we need to make a decision. Okay. Just make sure that we're pre-oxygenating this patient, positive pressure ventilations. This is a great patient to do the GAF technique where the patient's sitting up, maybe either semi-Fowlers or high Fowlers, and we do a two-person technique where we'll intubate, again, the patient seated up. But yes, this patient requires aggressive airway management. If you treat this patient like a classic CHF, they'll code on you. And one thing I want to tell you about cardiac arrest with these type of patients is they're going straight into PEA or asystole. like their electrolytes are depleted. They do not throw any rhythms that we can really work with. So typically, when I see a patient like this and they code, we're CPR and epi, right? But yes, I promise you, you will run into this patient. Just be mindful. It's okay to stay and play, right? It's okay to make the decision. Hey, we're going to go ahead and take over the airway right here, right now. I don't need to load the patient up and get back to a truck or anything like that. Let's do it now. Obviously, if you have the meds. If you don't have the meds, you're kind of put in a tight spot. The last number 5, the last presentation I want to talk about is one that you might not suspect. Okay, we have a patient that is tachypnic, desatting. They are a cardiac patient. Okay, so they have maybe cardiac medications, high blood pressure. You're seeing all the usual signs of a cardiac patient, but you hear bilateral wheezing. Okay, bilateral wheezing. The first thing I always tell people to ask: do you have history of COPD and do you have history of asthma? If the answer is no, I now need to do a detailed secondary. I need to see, is there any hives? Do I notice any angioedema or swollen tongue or lips or anything like that? Am I suspecting allergic reaction? And I need to make a decision. Am I treating a patient that is wheezing because of an allergic reaction and I just don't see anything? Or am I treating a cardiac patient? Don't think that all CHF patients are going to have rails or crackles. It is possible that we will hear wheezing. Again, throw on your end-tidal capnographies. My end-tidals, I'm looking for narrow plateaus. Okay, I'm looking for narrow plateaus, and I'm paying attention to my patient's medication list. I'm paying attention to my patient's blood pressure. If we start seeing those really high blood pressures, it should be a light bulb should be going off, right? We should be able to make a decision on which route am I going to be going. We need to treat these patients like a classic, right? We're going to be doing the CPAP. We're going to be doing the nitroglycerin. And if you do carry Lasix and that's in your protocol, we're going to be using Lasix as well. Okay. So again, these calls are, I don't want to say run of the mill every shift type calls, depending on where you work, but understand that you might see all 5 of these presentations. And I want you to be prepared for it. For those of you that are in school, I want you to be comfortable with managing all 5 presentations and being able to say, hey, this presentation requires a pressor and maybe a non-rebreather, not CPAP, right? We need to be able to alter our treatment depending on the stage of CHF. I hope this helped. If you have any questions, if you want to chime in the comments, please do so. And if there is something that you guys want to talk about maybe in the future, I'm thinking about doing little segments like this where I go over different presentations that I've seen and different treatments that are out there for these patients. Let me know. As always, like and subscribe. That helps support the channel. I plan on making a lot more of these type of videos. So again, let me know what you guys want to see.